For our next speaker, I'm just going to pull up my slides here. So our next speaker is Gillian Barrie. She's a registered occupational therapist and our CEO at the Alzheimer Society of Durham, and a seasoned healthcare leader with over a decade of experience in community-based dementia care. Since joining the Alzheimer Society of Durham region in 2019, she has led strategic initiatives to expand service, promote health equity, and foster dementia-friendly communities. Gillian is known for her collaborative approach, evidence-based leadership, and commitment to improving the lives of people living with dementia and their care partners. She also serves as chair of the Seniors Care Network Board and contributes to regional aging and dementia care initiatives. Born and raised on a dairy farm, Gillian enjoys growing food and flowers at her home and loves spending time outdoors with her family. We'll have a little bit of time for questions at the end. So if you want to put that in the chat or the Q&A, we'll do our best to get to as many as possible. But Gillian will be taking us through lessons learned from her trip to Denmark last year and rethinking community dementia care. So take it away, Gillian. You should be able to share your screen.
Wonderful, thank you. I'm going to do that. And can everybody see that okay?
Yep.
Awesome, okay. Okay, well, thank you for inviting me. I feel like I have big shoes to fill after Russ.
Oh, hold on. Sorry, Gillian.
Oh,
It's in presenter view, so we can see the next slide as well.
oh, okay. How do I change that?
If you right click, you should be able to turn it off.
Okay, what can you see now?
Now we see like in PowerPoint, so we can see. If you click from beginning.
Yeah, it's not going for some reason.
Maybe stop sharing and then share again.
Yeah, I think it's my 2-monitor setup, I think, is giving me trouble. Let's just do this. See if this works better. What can you see now?
The full slide. You're good now.
Okay. All right. I will work from this one. Okay. Thank you. Sorry about that. So thank you everyone for inviting me to come and for letting me speak. Like I said, I think I have big shoes to fill for Russ. I'm really excited though to be able to share a little bit about our trip from Denmark and talk a bit about what we're planning to do and maybe hopefully inspire some other people to rethink a bit about community dementia care at their own sort of local organizations. A bit about me, you heard from my bio, but I am an occupational therapist by background. So if there are any OTs on the call, you might hear some of my OT speak come out. But I am a nonprofit community support service leader. I've been very grateful to have this role for the last 4 years. I don't have any financial interests or conflicts other than my role here at ASDR. And I just wanted to preface by saying I am not a Denmark expert. So if there are questions about Denmark specifically, I can direct you to the right people to answer those. And all opinions that I express here today are my own. So a little bit about us at ASDR. Hopefully you're familiar with us. But if you're not, we are a nonprofit community support service provider. We've been around for over 40 years. You can read our vision mission up there. And we're very, we're unique in the sense, and I'm sure there's other people from other societies on here that, we serve different groups of clients. So we have our registered clients, which are people living with dementia, as well as care partners. And then we also serve our non-registered clients or sort of the general public. Oftentimes when people ask me about what we do, I get sort of, like, how much time do you have? Because we do a lot. And I often talk about our services sort of along the dementia journey, and whether or not you're sort of seeking our services from, right from I have concerns about my memory to now I've been diagnosed, or maybe I'm a healthcare professional or a student who's looking for more information, education, training. We sort of do it all. And when I talk about services, it really depends on sort of where you're at in the journey where you might experience different things. So you might be with us right from the beginning, or you might come in at different times. We also do a lot of public education, as is the case of this conference, and do quite a bit of public education around dementia-friendly communities, our local businesses and organizations, the training, as I mentioned, again, for healthcare providers and students. Hopefully, most people on this call have you first training or GPA. And then we do a lot of advocacy in other ways, whether it's locally or as well as provincially. And a lot of what we do is in collaboration with our community partners. We love our partners. They help us do quite a bit. I'll talk a little bit more about some of our partnerships as we go, but really we partner around being able to support capacity building. We could also work with different people when it comes to crossover and programming, maybe sharing space, as well as opportunities for research and best practice approaches. So that's a little bit about us. And I think maybe we'll get into what we're all sort of familiar with, and I guess the reality that we're living right now, which is our dementia and caregiving cases on the rise. So it's no probably news to anyone on this call that we're facing a significant increase in the number of people that will be diagnosed with dementia over the next, I guess now 24 years. And all of this information, the research and the image you see there comes from the landmark study from the Alzheimer's Society of Canada. But, looking at the trends and seeing that sort of significant increase, we also know that there are gender disparities. Women tend to be diagnosed more than men. We have our Indigenous and visible minorities facing sort of that higher increase. And that's talked about a lot in the landmark study number 2. And thinking about not just the dementia diagnoses that are happening, but then what does the care look like around those diagnoses? So I love in the landmark study how they put it in perspective around care partners, and particularly unpaid care partners providing hours of care. And so they say, in Ontario, care partners are expected to provide an estimated 5 million hours of care weekly, which if you put that into, a full-time job, it's the equivalent of 128,000 full-time jobs. And I think that is very significant because we need to think about how we are going to handle that as we move forward into the future, and what does our skilled dementia workforce really look like? So thinking about, are people wanting to work in this field? Are they coming out of school with the skills and education that they need? Our focus has been, and it continues to be, that we really feel passionately about growing that skilled dementia workforce. In Durham, there's more than 12,000 people that live with dementia, but that's going to be likely over 20,000 in the next 4 or 5 years. So that comes into play. The idea around the skilled dementia workforce sort of comes into play when we talk about our partnerships. And that's really where the opportunity to go to Denmark came from, was a partnership and a relationship that we have with our local college, Durham College. And we actually work with them very closely. Sorry, my slides are not progressing the same. We work with them very closely in various ways, providing education to their students, but also working with their educators. And when they came to us and said, we have a faculty-led classroom abroad program, and we want to take our PSW students to Denmark to learn about dementia care, and we're also going to bring journalism and videography students. Would you like to join us? I think we thought, absolutely, we would love to. And, for us, we were also thinking about the fact that Denmark, it's sort of similar to Canada in terms of our health systems, economy, government structures, that sort of thing, obviously much smaller than Canada. We also knew that, Denmark is sort of highly regarded when it comes to their national dementia strategy. Actually, if you've read the Brainwell Institute's Mind the Gap, they sort of shout out Denmark, and they talk about some of their indicators that they have. And we also knew that Denmark had a dementia town. So Svendborg is a town in Denmark that has a long-term care home that actually has used some dementia village type of models for building different elements of their long-term care home, one specifically that they now call a dementia town. And that will sort of come up a little bit later as to why we were sort of interested in that model. But we thought it was a great opportunity for us to explore dementia in another country, and really get some insight, and also sort of shape our students learning and sort of get them to compare and contrast between the two, Canada and Denmark. So we actually were able to work with Durham College, and they were working with the Danish. It was the sort of consulate that they were able to figure out our actual itinerary. And sorry, it was a Danish Trade Council. They put together the itinerary, and we were very grateful to them because they did a fantastic job sort of picking sites that allowed us to see different services. So it could be community. We went to several long-term care homes. We went and visited the Danish Dementia Research Center, which is sort of the clinical piece of this. We also got to visit our counterpart, so the Alzheimer Society sort of over there, which is called Alzheimer Rethinking. And they were very gracious in hosting us and sort of sharing a bit about their role. That picture there that you see is myself and one of our staff, Andrea, who accompanied me. And that is us outside of the Svendborg Dementia Town. So I'll talk a little bit more about what we saw there. So a little bit about Denmark, and again, not an expert, but just sort of what I picked up as we went along, is that yes, much smaller country than Canada. The population is less than 6 million. But when you think about dementia rates, and if you think about that image I showed earlier with the drastic increase, Denmark is in a similar situation. So they have about 97,000 people over the age of 65 who live with dementia right now. That is expected to grow to 145,000 by 2040. So same kind of steep increase. The main difference that we really noticed, and I'll talk a little bit more about this, is just how they manage non-hospital care. So community-based care, long-term care, it's all managed at the municipal level. And Denmark is made up of 98 municipalities. And so again, the municipalities have sort of that oversight for non-hospital care. And what was really interesting is they have a national dementia strategy, and that's set out by, the ministries, the Ministry of Health and Ministry of Elder Care, and they sort of work together. They set the policies and legislation. The KL provides the oversight for other municipalities, and we actually got to go and visit and meet with the KL. So they sort of set that oversight, and then it's the organization sort of in the municipalities that are actually delivering the services and sort of meeting those targets and KPIs that they've had set at the ministry level. And I mean, we know that Denmark sort of spends their tax dollars a little differently. 54% of their local healthcare spending is spent on elder care. And there was definitely a feeling that that is what people want, and they are supportive of that. There was a very strong culture of trust between citizens as well as between citizens and their government. And we saw that just even in how different organizations were working together, but also how they share their information and data. So, everybody in Denmark sort of has an identifier, not unlike what we have with our OHIP cards, but it's used for everything. So it tracks sort of demographic information, education, healthcare, all of those things. And that means that each municipality sort of has detailed information about their own residents, and they can start to make decisions that would best reflect and best serve their municipalities. So that was very interesting. I'll talk a little bit more about one initiative that one of the municipalities was doing. But just seeing that there was this trust that, like, yes, you can have my data, and yes, I would love for you to be able to, tailor things based on where I live and sort of what the communities look like. We also saw really collaborative working relationships. So again, everybody's sort of working in this same direction. There didn't seem to be, like toe stepping or people feeling like, well, that's what we do or that's what they do. It seemed like everybody really had defined roles. And actually, we talked about one of the awareness campaigns that they had, which was called Better Life with Dementia. And the Alzheimer Vereningen did the awareness piece and sort of drove the education, but the Danish Dementia Research Center provided all of the data. And so they were working together, and they, were very complementary of each other. And I think overall, we felt like that was sort of the general vibe, was this idea that there was very strong emphasis on community, social welfare, and volunteerism. And one of the researchers said to us, no one in Denmark is very rich, but also no one in Denmark is very poor either. And this idea that they sort of work to live, they don't live to work. And once you're done working, that you would go back and volunteer. But again, they're also knowing that the government is paying for a lot of their healthcare as they get older as well. So very interesting. And again, if you have more information or you want more information about Denmark, I can certainly direct you to the right people. But in terms of dementia in Denmark, I'll talk a little bit about generally what we saw and then talk some more about some of the programs that I thought were just fantastic. But I think the big takeaway was that we really felt like in all areas that we visited, so whether it was, clinical, community, long-term care, dignity and autonomy were the key principles of elder care. Like first and foremost was the dignity and autonomy pieces. In one particular area we visited, and that's actually that large picture you see at the top there, that was in a municipality where we went to visit a place called Paletten. It was like a community center, sort of. They had a day program for people with dementia. We had just done a very active line dancing class after that picture, and they were very serious about it. And they really encourage their residents in that municipality to be active, to do sort of active programming, this idea around sort of rehabilitation, which we don't talk a whole lot about in terms of dementia in Canada. And then they really were focused on health promotion, wellness, and early detection because they really felt like that was the sort of key to be able to preserve and maintain function. So one of the KL representatives, and she's in that second picture there, she explained to us a little bit about one of their early prevention programs. So they actually have a program where, and again, because they have information about their residents, they were able to have a list of people in their community that they were turning 70. They would get a preventative health call at the age of 70. And the people responsible for that were healthcare providers, nurses, OTs, that sort of thing. And they would get the call saying, do you mind if we come out for a visit? Sure, come out. And they would sort of look and see, maybe you need to be thinking about your house and the safety of it. And maybe you need grab bars. Maybe you need to downsize. How are you managing your ADLs and your functioning? Maybe you need to be going to a program. You should be more active. How's your memory? We should do a screen. I'm going to refer you on. So they're very proactive in that. And I think the key was they weren't doing the things for the residents. They were telling them what the residents needed to do in order to live well, live independently as long as possible, again, preserving and maintaining their function. And there's that buy-in that like, yes, we all agree that this is important. And so because they're sort of focused on this early prevention, they actually have more people living at home or in the community longer that they actually can push long-term care to really be more sort of end-of-life care. The average length of stay in long-term care there was 2.5 years. Most people had some form of dementia. They said about, I think it was 75 to 85%. We definitely saw that in the long-term cares that we visited. But again, because they're sort of in this sort of like, let's really promote the community piece of it and not necessarily default to long-term care, they have limited specialized long-term care facilities for dementia. So they don't necessarily need as many beds than they would necessarily in other situations. So that Svendborg Dementia Town was really like one of the only specialized long-term care homes for dementia. And it wasn't only for people with dementia, it was just a piece of it. But the fact that they know that the majority of their residents need that sort of design, that they were willing to sort of make those changes. So I'll talk a little bit more about that. In terms of the care models that we saw, these might be familiar to some people, but the person-centered care, the Tom Kitwood's Flower of Psychological Needs was sort of the predominant model that we saw. So people might remember Tom Kitwood was the one who famously said, when you've met one person with dementia, you've met one person with dementia. And that model is really about love being at the center of all care, and the idea that every person is unique, everyone comes with their own unique needs, and this idea of sort of creating comfort and attachment. And what was really interesting about that was this model sort of promotes that if you're a care provider, you're not just giving care, but you're also receiving as well. And we really saw that when we were in certain situations where the staff were much more friendly with the clients or the residents than what we might be feeling comfortable with. lots of hand holding, hugging, knowing a lot about the staff's personal life. It was like a real sort of family community dynamic, which I think, the students maybe were a little bit more shocked because they had just come from a placement and thought, I don't think that would really fly. But the staff said, particularly staff in long-term care, they said, it is an honor for us to be able to work in this environment where we know this is where these people will spend the last of their days. So it's a very different sort of mindset. And we did see also the Best Life Memory Care approach, or sort of the greenhouse project, where they really focus on retaining abilities as much as possible. So we saw this a lot at the Dementia Town, which was to create an environment where they want people to do as much as they can. So what they can, if they can, for as long as they can. And that includes allowing them to live with a bit of risk. So, the idea with the Dementia Town was there is an outdoor space that is free for people to go out and walk around. There's a tool shop where you can do, woodworking, all the tools you need, a pond that is open. You can walk around, you can, go wherever you would like. And there's this idea that, this is what people would like to do. This is what we can build for them. That's a life as closest to the life that they had before they had dementia. And again, this is where we were sort of like, aren't you worried about, them going in the pond, or aren't you worried that they would leave? And the staff are sort of like, no, like we've created this environment that they want to stay, right? And that they want to be here. This is their home. And that sort of brings me to somatic approaches, which really is around the built environment. And so I'll talk a bit more about this because I think this is something that is probably easy for us to achieve, but also needs some sort of intention behind it. And that is sort of linked also to green dementia care, which we saw quite a bit of, and sort of reflects the fact that that is a big piece of Danish culture, right? Being outside, biking, hiking, all of those things. So there was obviously going to be green elements and nature sort of immersed within their spaces. So a somatic approach to design is really about sort of being intentional about how you're designing the space, but also sort of creating this restorative environment that is also accessible. So really thinking about thoughtful use around light, sound, textures, integrating elements that might foster different sort of like connection, renewal. The nursing home of the future, which is that picture down at the bottom with the large windows and that sort of living wall. They were talking about the fact that it is a legal requirement for staff or any worker, I guess, in Denmark to have access to natural light in their workspaces. So yes, the windows are beautiful and yes, they provide natural light, but it's also a requirement that the staff have access to that, which we thought was amazing. Also with the nursing home of the future, they use specific sort of sound tiles in the roof to sort of dampen any echoing. So again, the space, even though it was open and wide and very sort of like there was an open space you can't really see in the picture, but it didn't feel echoey. Like it felt very sort of comfortable. And they use technology for certain things, like, using technology as a way to manage risk. So things like, motion detection, tracking devices. If people wanted to go outside, it was like, yeah, no problem, but you need to wear this bracelet. And so they had sort of that in place. As I mentioned, the inclusion of green space. So, even the research center, which is in a hospital, had a courtyard with green space. So that's that middle picture there. And it had different stations with music therapy, with different sort of horticulture pieces. You could do like herb, different smelling, olfactory sort of stuff with herbs. And that was just right at the hospital. And I think what was really sort of lovely about this was, yes, this definitely helped with, people living with dementia sort of having access to these spaces. And we know like a lot of this is supported in evidence around sort of managing BPSD, or even just giving people sort of that nature feeling and all of that. But it was the community like surrounding that really also loved the spaces. So for example, at the Dementia Town, like the community could come in. That picture up there of the boutique, that was in the long-term care home where they actually had a secondhand shop. You could come in and shop there as a community member. The nursing home of the future as well, the residents that live around want to come inside because they're doing really fun stuff. There's sing-alongs, there's different things happening. And once they come in, they have a coffee, then they decide to volunteer, and then they decide that they want to be involved in different ways and they're familiar with the building. So this idea of sort of integrating these approaches that it supports more than just the people who are using the space, or living in the space. So this is all things that we learned from Denmark. We're sort of coming home, we're brimming with excitement, and we're sort of thinking, how do we use some of this information at home? And so I want to talk a little bit about what we are doing at ASDR, but also maybe give you some thoughts too around what you could be doing in your own practice or at your own organizations. And I don't want to miss over or skip over the piece that I know that there is a lot of work going on at the provincial and federal levels to address sort of gaps in our national dementia strategy. I'm not going to touch on that today. I think we have lots of great partners that are working hard to address those, including, all the work around the DMTs that have just been approved. But for the purpose of this presentation, I am going to sort of stick to local initiatives that don't necessarily require legislative changes or say like a major additional resources. So these are just some ideas that we're sort of mulling over right now and sort of thinking about as we are in our strategic planning phase. We'll have a new strategic plan come April. So thinking about prioritizing health promotion and prevention. I think we do this, maybe we don't do it enough, or we're not all sort of driving the same message, which is brain health in general. Brain health education and awareness can start early. We've talked about it with, addressing it with young children, sort of a public health initiative. So doing a lot more around talking about brain health and also involving primary care. So thinking about social prescribing, sort of been the buzzword, but also, are we setting ourselves up to be known for our services where, yes, you could socially prescribe a day program or a active living program. Here it is on our referral form. So thinking about ways that we can be very intentional about that. Frailty status is another one. That's something that we're currently working on, but it's becoming more and more common in different systems. So whether it's, acute care, primary care, specialized geriatrics for us, but all sort of talking in this frailty status language, which is common, and we can all sort of work towards addressing frailty and sort of looking at, are they coming from one area to another, and what's happening in terms of their frailty status, and are they becoming more frail or less, and how do we sort of deter that from getting worse? And then early detection and screening, that is something that, we were doing with our memory clinic team in primary care before. We've since added on a cognitive screening program, as well as our work with the Ontario Brain Institute around the dementia registry. So we're planning to continue that. That is our way of sort of supporting primary care and sort of getting ahead of it. We've had actually quite a few people come in just saying, I'm just curious about my baseline. Mom and dad had dementia. I'm sort of noticing some things. My doctor thought it might be a good idea. And so they've been screened, and then we can sort of have that baseline to sort of continue on. So we'll be continuing that at our offices actually ongoing. And then the next one is this is where my OT is going to sort of come out a little bit, but that's around cognitive rehab. I don't think we do enough of this. I don't think we talk about it enough, and I don't think we call it out enough. But this is around actually creating rehab goals when someone has dementia. So there's been a couple of programs that have been developed over the years. Some of you might be familiar with Learning the Ropes for Living with MCI, which was developed by Baycrest, but also looking at other sort of cognitive behavioral therapy or cognitive stimulation therapy, which we have had our staff trained to deliver. And I think that's really important to look at actually utilizing healthcare providers with specialty training in community settings, where we could start to build in some of those programming that would actually allow people to set goals around their cognition, allow them to maintain their current cognition for as long as possible. And then lastly, which I'll spend a little bit more time on, is really around the community space design and long-term care home design. I think the somatic approach has something to it, and I think we do it in certain ways, but maybe we're not calling it what it is and maybe not being as intentional, but this would really allow us to think about the dignity of risk, actually incorporate dementia-friendly and somatic design approaches. You start to hear more about it. I think I just read there was a home in Toronto, long-term care home that was starting doing some of those things. So you're starting to see it. Obviously, the village model becoming more popular, but also thinking about how we add in natural environments and encourage community so that we're not sort of seen as a, oh, well, I don't belong there. That's not for me. Sort of looking at bringing the community into spaces so that we can help reduce stigma, drive awareness, all of those things. So for us at ASDR, we're sort of thinking about, well, how can we do something here? And what's our role here? If we put all of those sort of things that are important, and, I think the list here probably is longer than what I've listed there, but all the things we would love to see in community-based dementia care, coordinated care, a dementia-friendly design, access to a diagnosis, the rehab piece, making sure our caregivers are taken care of and that they have their own wellness opportunities and respite. What are the alternatives to long-term care, right? So what do we have available? And tech and research and that idea that we want to grow a skilled dementia workforce. So if we put all that into our blender, so to speak, we're sort of thinking about this as a new model of innovative community-based dementia care. And that's where sort of some of our partnerships come into play, particularly our partnership in research with Ontario Tech University, who is helping us do a little bit more research around if we were going to develop a new model, what does that look like? And so I'll share with you, and drum roll, this is actually the first time we've shared this publicly, is sort of the goal and vision of ASDR for the future. And it's supported by our partnership with Ontario Tech, like I said, who is currently doing some research into a social and economic impact study. But this is sort of what we envision, which we're calling right now a dementia care campus. And that really is looking at building a new space that would incorporate some of those dementia-friendly somatic design principles, bring in the village model of design. For us, this is a day use facility. This would be the site of ASDR. We would be looking at adding some overnight respite options. Not pictured in the concept design is obviously green space, but the idea that we're sort of incorporating some of the village type of models and that sort of flow of the somatic design. There's a cinema, a library, a teaching kitchen, there's a sensory room, there's multi-purpose rooms, but also looking at, could primary care integrate with this? Could we look at doing on-site testing? And then ultimately, this space would also function as a living lab for students. And that's where that idea that we want some sort of on-site and integrated sort of experiential learning happening. So we are currently working on this. We're looking to acquire land and or a building. So I've sort of put it out there as a teaser that we are actually now officially launched our new website, which is dementiacarecampus.ca. It is coming soon. We'll be tracking all of our progress, and you'll be able to read about some of the research that we've been doing, as well as, again, some of the landmark pieces that we've been adding to this. You can sign up on the site for information if you want to stay connected, or if you are interested in partnering or collaborating, of a building or a site that you think would be fantastic, or your organization is interested, please get in touch with me. We're happy to talk. And I think that brings me to the end. I think I have a slide for questions. Yes, there we go.
Perfect. Thanks, Gillian. If there's any questions, you can put them in the chat. There's just lots of emojis floating everywhere,
Oh,
hand
good.
claps, hearts, bursting hearts even.
Can't see everybody, so I'm struggling a little bit to see. Oh, there we go.
I don't see. Oh, a question in the chat. Do you know how they determine eligibility for their home care services in Denmark?
I don't know specifics, but I would say that it didn't seem like like if you're in need, it was sort of, yes, you get it. I will say one thing that was interesting was when they put in what we would, I say, call a PSW, which they call helpers. Um, it was not to put in the support to do the task for you. So here we often will put a PSW in, you need help with bathing. You get a PSW to come for home care and they help you and assist you. Their sort of goal with putting a helper in was actually to do more of that rehab and the goal and the training. So I'm here, but I'm going to encourage you to do as much as you can yourself to possibly get you back to not needing me. So it was really sort of promoting the independence piece. But like a lot of home care services, yes, was funded by the government. People also did have some private insurance as well. So I don't know exactly how they decide who's eligible, but it was definitely an option.
And Jordell has a question. Oh, she disappeared. I was gonna,
Here, sorry, I just
oh,
lowered
there we
my
go.
hand too quickly. Um, I'm sure you probably answered this, but I wanted to know, so when you coordinated to see the dementia village, correct? How
Yeah.
did that happen? I'm sure you answered it, but I apologize.
So the Danish Dementia Trade Council was in charge of booking all of our sites. So they actually set up the visits for us when we were there. And I'm specific to say it's a town, and they were very specific to say town because they didn't build a standalone village, which is sort of the traditional model. They actually renovated their long-term care home to add village-like pieces. And so they felt that it was better to call it a town. They did it also in like with consultation with the original Dementia Village builders. So there's a whole Dementia Village Associates group that provides consultation when you're thinking about this. So they had a full guest book and they have lots of visitors. So it seems like they are a very popular destination if you're going and looking for dementia, specific sites, I guess, that they would welcome people, but it was set up through the Trade Council. I see a question there.
And then there's another question. Do they encourage a lot of recreation activities? I don't think you talked about the line dancing as much as I've heard of it.
Oh yes, the line dancing. I did more line dancing there in a week than I've done my whole life. They definitely love the line dancing, and yes, recreation was huge. So I didn't actually talk about it. Oh, and I see Kimberly. Hi, Kimberly. She was one of the people that came with us. So the specific picture I had of the bike, that was a wheelchair with a cover and a bike on the back. That was for people to go on bike rides. And the reason there was a cover was because they even go if it's pouring rain. And so, like, the staff volunteers would be taking people from the dementia town out on bike rides. There was also a group, it was part of the Paletton Day program, but they had a group that did hiking every week, and there was one group that did sort of a shorter hike, like 1 kilometer, versus the other group would do like 5 kilometers or something. Like they would be gone for hours, and they would embed in that some different types of reminiscence therapy. So they would take pictures when they were hiking, and then they would reminisce about what they saw on the bus ride back. Again, all weather conditions. So they were going in all different areas. So yeah, the recreation piece was huge. It was most of what we saw. You're welcome, Kara.
There's another question. Was the community volunteer support the backbone of the interventions and stimulating activities? What were the staff/resident ratios like to achieve the
Mm,
rehabilitation efforts?
yeah, good questions. So the volunteer piece, I don't have hard numbers, but there was quite a bit of volunteer support. It was hard to know who was a volunteer and who was a staff, honestly. So we didn't always know. Sometimes we would be like, "Oh no, I'm a volunteer. I come here every day." But again, it was that idea that the community sort of supported these initiatives. I will say the Dementia Town too. We actually heard from, I think, what would be equivalent to say like our MPP. They were there at our visit, and they talked about the fact that yes, there was some municipal funding that went into the renovation of the Dementia Town, but also they did a lot of fundraising. Like they're, again, what would be equivalent to our like boards did quite a bit of fundraising. They did all of that. So like I would imagine the volunteer in all capacity was, yes, definitely a backbone. What was the rest of that question?
Before I do that, just about the volunteerism. The
Yes.
culture of volunteering there is very
Yes.
different than it is here.
Very different.
People
The
retire
fact
and it's
that
like expected, right?
absolutely, yeah, and they people like that's how they spend their retirement is they give back. Yeah.
And the second part, sorry, was what were the staff resident ratios like?
So of the long-term care homes we saw, they were definitely smaller homes. So I think if I recall correctly, don't quote me, but I think the nursing home of the future had less than 70 beds. So it was a small home, so the staffing ratios were definitely higher. I don't know offhand, but they had a different structure as well in terms of again like helpers, sort of equivalent to PSWs, and then also like nurses having more of a role than say primary care here. And then they did have some primary care that sort of visited the homes. In terms of like I'm trying to think. I don't know it offhand, but obviously less because there was quite a bit of staff and much fewer residents. Yeah.
That's it for questions. Unless
Okay,
anybody's
I
typing.
didn't realize Kimberly was on the call, but I'll give her a shout out as one of our educators that came with us from Durham College. Wonderful to have her. And yes, I'm sure there's probably others too. I don't know who else is on the call, but it was an amazing experience. And if you do ever get a chance to check it out, very good. Yeah.
Awesome. Well, thank you, Gillian, so much for providing that session for us. We are going to go on lunch until 12:30. So we'll close this room. You'll end up back in the main room. And then when we come back at 12:30, you'll get to pick which room that you would like to go to. So enjoy the next 33 minutes of a break, everybody. Go get something to eat, stretch your legs, and we'll see you soon.